Well, okay, it's recording like this. I need to change the settings on my camera back to how they were before. Oh well, that's just the way it's gonna be now. Okay. So today, today's video is going to be about drugs used for mania and bipolar. So anti-manic drugs, I'm using the so this is all true information, all reliable. Okay, anti-manic drugs are used to control acute attacks and to prevent reoccurrence of episodes of mania or hypomania. Long-term treatment of bipolar disorder should continue for at least 2 years from the last manic episode, up to 5 years if the patient has risk factors for relapse. Let's see what these risk factors are. Oh, maybe not. Okay, an antidepressant drug may also be required for the treatment of coexisting depression, but should be avoided in patients with rapid cycling bipolar disorder, a recent history of hypomania, or with rapid mood fluctuations. Benzodiazepines. Benzodiazepines, such as lorazepam, may be helpful in the initial stages of treatment for behavioural disturbance or agitation. They should not be used for long periods because of the risk of dependence. So that's very key with benzodiazepines. Antipsychotic drugs, normally olanzapine, quetiapine, and risperidone, are useful in acute episodes of mania, hypomania. If the response to antipsychotic drugs is inadequate, lithium or valproate may be added. An antipsychotic drug may be used concomitantly, which means together, with lithium or valproate in the initial treatment of severe acute mania. Olanzapine can be used for long-term management of bipolar disorder in patients whose manic episodes respond to olanzapine. Okay. It can be given as a monotherapy or in combination with lithium or valproate if the patient has frequent relapses or continuing functional impairment. So lithium is more of a stabilizer, as I've heard. So that usually is given to people with severe bipolar disorder. So the rapid cycling, which was referred to before, is when a person quickly shifts from depressive bipolar to manic, so it's extreme high and then to extreme low. So that's rapid cycling. Azanapine, a second generation antipsychotic, is licensed for treatment of moderate to severe manic episodes associated with bipolar disorder. When discontinuing antipsychotics, the dose should be reduced gradually over at least 4 weeks. 4 weeks, that's probably key. If the patient is continuing with other anti-manic drugs, if the patient is not continuing with other manic drugs, or if there is a history of manic relapse, a withdrawal period of up to 3 months should be considered. So if a person is on medication, 4 weeks withdrawal period, and if no other drugs are available to manage the treatment, or the patient is currently not taking any other drugs concomitantly, then you would need to provide 3 months of withdrawal period. Okay, so these drugs the drugs that can be provided for bipolar disorder are carbamazepine, may be used under specialist supervision for the prophylaxis of bipolar disorder, manic depressive disorder. Okay. In patients unresponsive to a combination of other prophylactic drugs, it is used in patients with rapid cycling, manic depressive illness, 4 or more effective episodes per year. So that is rapid cycling. So if you get those 4 manic episodes per year, so that's a lot. Okay, the dose of carbamazepine should not normally be increased if an acute episode of mania occurs. So that wouldn't help. Okay, valproic acid as the semi-sodium salt and sodium valproate, are used for the treatment of manic episodes associated with bipolar disorder. Valproate, valproic acid below, and sodium valproate is also used for the prophylaxis of bipolar disorder. However, it should not normally be prescribed for women of childbearing potential because it's teratogenic. In patients with frequent relapse or continuing functional impairment, consider switching therapy to lithium or olanzapine, or adding lithium or olanzapine to valproate. If a patient taking valproate experiences an acute episode of mania that is not ameliorated or improved by increasing the valproate dose, consider concomitant therapy with olanzapine, quetiapine, or risperidone. So if mania is not controlled, you usually have to consider concomitant or combined treatments, so adjunct therapy. Having something like valproate as well as olanzapine, increasing dosages usually don't help. So carbamazepine, that's why, although it's being used to treat rapid cycling manic depressive illness where there's 4 or more episodes of this disease a year, increasing dose would not help control or manage the condition, so that's why it's not recommended. So instead, try and put the patient on another antipsychotic such as olanzapine, quetiapine, risperidone, etc. Okay, lithium salts. Lithium salts are used in the prophylaxis and treatment of mania, hypomania, and depression in bipolar disorder, manic depressive disorder, and in prophylaxis and treatment of recurrent unipolar depression. Lithium is also used as concomitant therapy with antidepressant medication in patients who have had incomplete response to treatment for acute bipolar depression, and to augment other antidepressants in patients with treatment-resistant depression. It is also licensed for treatment of aggressive or self-harming behaviour. So lithium is usually prescribed for very severe cases, so if it's very severe mania, very severe depression, so depression which is resistant to any other antidepressants, such as SRIs, monoamine oxidase inhibitors, tricyclic. So those 3 major groups, if the patient has depression that is resistant to those groups of medications, then it's best to put the patient on lithium. Or if this also seems to be the case for if the patient is on severe manic unipolar depression, manic bipolar, which means that they can be very aggressive or self-harming during those periods of times. Or maybe that's depression. That's the depression side of it. The manic is when it's too happy, so yeah. The decision to give prophylactic lithium requires specialist advice, and must be based on careful consideration of the likelihood of recurrence in the individual patient and the benefit of treatment weighed against the risks. The full prophylactic effect of lithium may not occur for 6 to 12 months after the initiation of therapy. So it may take a while for the actual beneficial effects to take place. Such is the same with SSRIs, where they can take over 4 weeks, I believe, to take effect. So that's the same. In this case, it's 6 to 12 months for an effect to occur. Olanzapine or valproate given alone as adjunct therapy with lithium are alternative prophylactic treatments in patients who experience frequent relapses or continued functional impairment. Okay. That's bipolar disorder. So valproic acid, treatment of manic episodes associated with bipolar disorder, usually give 750 mg daily, 2-3 divided doses. then increase to 1 to 2 grams daily, adjust according to response. Doses greater than 45 milligrams per kilogram require careful monitoring. So if it's over 45 milligrams per kilogram daily, you need to monitor this patient. Side effects. Conception and contraceptive operate is associated with teratogenic risks and should not be used in women of childbearing potential unless there is no safer alternative. This should be fully considered and discussed before prescribing for a woman of childbearing age. Effective contraception advised in women of childbearing potential. Pregnancy. Valproate is associated with highest risk major minor congenital malformations, in particular neural tube defects, long-term neurodevelopmental effects. Valproate should not be used during pregnancy or in women of childbearing potential unless there is no safe alternative, as already been said before. After careful discussion of risks, if valproate is to be used during pregnancy, the lowest effective dose should be prescribed in divided doses to avoid peaks in plasma valproate concentrations. Doses greater than 1 gram daily associated with increased risk of pterogenicity. Specialist prenatal monitoring should be started when valproate has been taken in pregnancy. Neonatal bleeding related to hypofibronemia and neonatal hepatotoxicity also reported. The dose should be monitored carefully during pregnancy and after birth. Adjustment made on a clinical basis. So that's with that. Lithium salts. What is very important about this is treatment cessation. While there is no clear evidence of withdrawal or rebound psychosis, abrupt discontinuation of lithium increases the risk of relapse. If lithium is to be discontinued, the dose should be reduced gradually over a period of at least 4 weeks, preferably over a period of 3 months. So at least 4 weeks, but 3 months is obviously preferred. And patients and their carers should be warned of risk of relapse if lithium is discontinued abruptly. If lithium is stopped or is to be discontinued abruptly, consider changing therapy to atypical, antipsychotic, or valproate. So one of those atypicals, which was olanzapine, and or valproate. Not if you are of childbearing potential. Childbearing age potential. Yeah. So not for that. Patient carer advice. Driving skill task may impair performance of skilled task. Driving, operating machinery. Lithium treatment packs. A lithium treatment pack should be given to patients on initiation of treatment with lithium. The pack consists of a patient information booklet, lithium alert card, record book for tracking serum lithium